So welcome to an APAS production of William Shakespeare's The Comedy of Errors, or The Case Against Kinematic Alignment of Total Knees. The cast, which is not in plaster, but hopefully we'll get plastered in the bar afterwards. David is being played by me, and Goliath is being played by David from Great Britain. Completely unfair. So friends, surgeons and countrymen, lend me your ears. I've come here not to bury Barrett, but to appraise him of some facts. The evil that men do is remembered after their deaths, but the good is often buried with them. But Barrett is an honorable man. He was my friend. He was faithful and just to me. The 10 years that we worked on the Attune project, we had a great time. Very friendly. But now, after this kinematic alignment, Jon Barrett has a lean and hungry look. He thinks too much. Such men are dangerous. So what is kinematic alignment? The goal of kinematic alignment is to place the implant along the patient's premorbid joint line in the hope that you don't need to do much soft tissue release. Where is the premorbid joint line in some of our patients? How are we going to judge this in the presence of where? Okay, so on the femur, this is how it's described, how you position the femoral component. You measure with a caliper the amount of distal and posterior femoral resection after correcting for wear, cartilage and bone, and make sure that that equals the thickness of your condyles of your femoral component. O mighty Barrett, dost thou lie so low? Are all thy conquests, glories, triumphs, prospective studies shrunk to this little measure? And on the tibial side, the resection is made by placing an angel wing on the tibial jig parallel to the tibial surface. And before you make the cut, this is what Stephen Howell, who's designed this entire kinematic alignment stuff, he measures the anterior offset of the tibia with this caliper, reverse caliper. And then after doing the cut, he then changes that slope and the cut so that the insert thickness and the slope are adjusted so that he restores this position of the femur with respect to the tibia. Such stuff as dreams are made of. The fault, dear Barrett, lies not in our slopes, but in ourselves. So therefore, good Barrett, be prepared to hear 5 reasons why mechanical alignment is superior. And by that, mechanical alignment, we are talking about getting your HKA axis around 180 plus minus 3, and both your components roughly at 90 degrees to their mechanical axes. So the first is better survivorship, superior function, lower failure in obese patients. It's safer if there's extra-articular deformity, and there's a paucity of evidence for kinematic alignment. Let's see these one by one. Better survivorship. So if you place your component within 3 degrees, it reduces the risks of wear, loosening, and implant failure. So look at these two, both done at the same time. The right one goes on 13 years without any problems. The left one, a little bit of varus goes and the patient undergoes osteolysis, loosening, and needs a revision. Another example, 8 degrees of valgus on the femur, 3 degrees of varus on the tibia, acceptable overall alignment. Tibia starts to loosen, continues to loosen, and goes into severe varus, requiring a revision. Another example, severe deformity, 6 degrees of valgus on the femur, 4 degrees of varus on the tibia. Again, look at what's happening to the tibia. It collapses, goes into varus, requiring revision. Why does this happen? This is an excellent paper from Halder et al. The influence of limb alignment on mediolateral loading in total knee replacement. So they've said that 1 degree of varus increases the medial load by 5%, and there's a linear correlation with the limb alignment. Is Barrett sick, and is it physical to walk unaligned and suck up the humors? No, my Barrett, you have some sick offense within your mind. For Barrett is an honorable man. Second, better function. So there's this paper, which is a 5-year study, randomized controlled trial, 90 total knees at 5 years, looking at outcome and alignment. And they have shown that all the scores are much better if your alignment is within 3 degrees of neutral, and it diminishes if your alignment is outside that range. Not only that, there's another paper which again looks at if you have more than 3 degrees of average alignment of the components throughout the functional arc of motion, the patients will perform more poorly with daily activities. Upon my knees and those of my patients, I beseech you, sir, mend your ways. For Barrett is an honorable man. Lower failure in the obese. Look at the effect of alignment and BMI on failure of total knee replacement. And we are dealing all over the world with more and more obese patients, even in our country. 6,000 total knees, the failure rate according to tibial alignment. So if the tibia is kept in neutral or valgus, slight valgus, you see the failure rates very low. But the moment you put them in varus, look at what happens. Very high failure rate. What about the femoral component? So if it's in neutral, you see what's happening. But the moment you put this in significant valgus, your failure rate goes up. So this is effectively what happens in kinematic alignment. You tend to keep the tibia in a bit of varus, keep the femur in a bit of valgus. You might have a normal sort of mechanical HK axis, but eventually you are going to have failure of the components. A curse shall light upon the limbs of man if you do this. Okay, what about extra-articular deformity? Now we've shown this in our paper that we have inherent varus alignment of the lower limb, particularly in Asia, and the tibial plateau inclination is quite variable. Look at the spread of the data here. You can see the medial proximal tibial angle along this can vary from 92 to 80 degrees. In other words, that slope can be from 10 degrees of varus to 2 degrees of valgus. In a normal, non-arthritic 20 to 40-year-old knee. Okay, these are normal Asian adults. Now, if you have somebody with arthritis in such a patient, this is what his proximal tibia is because of the metaphyseal bowing. And if you're going to put in a stemmed component, look where it's going to get out. It's going to go out in the lateral cortex. Similarly, we have a high variation in the valgus correction angle. So that's the angle between the anatomical axis and the mechanical axis of the femur. So on the femoral side, the VCA can vary from 2 to 12 degrees and is only occasionally about 44% of the time in the 5 to 7 degree range. So if you have some patients like this in 3 degrees of, with 3 degree VCA, like in a valgus knee, you may have somebody in 12 degrees in a varus knee. So if it's a valgus knee, and you position your femoral component with kinematic alignment, you can see it'll remain in substantial valgus. On the other hand, we have patients with femoral bowing. Almost 1/5 of our patients have significant femoral bowing. So if you see on this side, on the left side is, if we superimpose a femoral component with kinematic alignment, that's how it's going to lie in almost 5 or 6 degrees of varus. On the other hand, you have 90 degrees with the mechanical axis, the joint line is restored. And if you did it with kinematic alignment, you're going to have substantial varus, almost 4 or 5 degrees on the femoral component. What about patella tracking? So if you use mechanical alignment, you would take off, in the usual fashion, a little more on the medial condyle, less on the lateral condyle. This is how your femur would be positioned. But if you did a kinematic alignment and took off more or less equal amounts, then you're going to have perhaps some degree of internal rotation, and think what that might do to your patella tracking. So the trochlear groove of most implants has not been designed to take care of this alteration of the trochlear groove. Into what dangers would you lead me, Barrett? Look at this patient with this implant put in, and it's going into varus because there's a severe extraarticular deformity. The tibia has collapsed into varus. Alas, my Lord, your wisdom is consumed in confidence. On the other hand, there's ample evidence to support neutral alignment. So why dost thou show to the apt thoughts of men the things that are not? A curse shall light upon the limbs of men. And lastly, I come to the paucity of evidence for kinematic alignment. And this is the main paper which shows that there's no difference in 2-year functional outcomes. This was a randomized controlled trial which received the Ranawat Award this year. So measure for measure, they've looked at every possible score, VAS, WOMAC, Oxford, EQ, etc. No difference at 2 years. But what was worrying was 30% of the tibias were...
Arun, I have to stop you there for a second.
Give me half a minute, sorry.
Okay. I'll give you extra.
Yeah, you give him half a minute extra as well. Give him 1 minute. So more than 5 degrees of varus on the tibial component. 1/3 of those tibias were in significant varus if you do a kinematic alignment, and that's very worrying. So no difference in scores, but unable to demonstrate an advantage in terms of pain or function that would justify this risk. Another paper saying the same thing. This was at 1 year. Again, a prospective, blinded, randomized trial showing no difference in function. So friends, I would give up all my fame for a pot of ale and safety. On the other hand, this paper is the first paper from Stephen Howell where he starts talking about failures of kinematically aligned total knees. So he's done 2,000 total knees. Only minimum follow-up is of 2 years. 8 patients have already failed, and this was at an average time of 28 months. So you notice that we still have a long way to go for the others to catch up at 28 months because minimum 2-year follow-up. So you can expect more failures. So this is how the femoral component is set relative to the native joint lines. You can see the amount of tilt on the tibia. And with this, the tibia goes into loosening because he's put the slope at 14 degrees, and this has failed. So beware the Ides of March and the Ides of Barrett. Let no man, such man, be trusted. Barrett is an honorable man. So the take-home message, better survivorship, superior function, lower failure in the obese. It's safer if you have extraarticular deformity, and there's a paucity of evidence for kinematic alignment. So kinematic alignment, I think, friends, is much ado about nothing. And total knee arthroplasty is not as you like it. Put it in any angle that you think is suitable. And finally, remember that all's well that bends well. Thank you.
I'll give you an extra minute or so there if you need it, okay? We'll make it equal. We'll make it fair.
I probably would just need about 3 minutes to get rid of Arun. So, debating Arun is a bit like England playing Germany football in Germany on Germany Day. It's like I'm taking one of the most famous Indian surgeons in knee surgery in India and trying to prove him wrong. So, well, that'll be easy, won't it? Okay? And it's very interesting that Arun has chosen the words of a long-dead playwright to hang his hat on. Because what I'm going to say is let's forget that old stuff, okay? Because we need to be moving into the current times to make sure that we move with the times and that we utilize the new knowledge we have, okay? So just remember that mechanical data isn't given to us by God or Shakespeare. It actually was invented because we didn't have much else to hold our hat on. We had 2-dimensional X-rays. And so we didn't have the ways we image now. We didn't have the understanding of 3-dimensional way that the knee moves. And so we had a lack of thought about what was happening in the 70s, and we certainly had a lack of understanding. And this was about as detailed as we got. We're looking at the knee in one plane with an X-ray taken in different ways with people with bad knees. And we didn't really understand things like anterior sliding of the femur. We didn't understand medial rotation, medial pivot, and lateral rollback when people thought about anatomic alignment. The knee was described as a hinge. And this is what we started off in the 1970s, when Arun was 5. And so here you can see a surgeon actually holding up a tibial jig with his hand, and he's actually marking it with an ink pen, and he would then cut freehand. And so that's what we started off with, and we started off with some alignment issues that you can see up there, which were clearly less than desirable. And so this is the paper that got everyone thinking. This is David Llewellyn's paper in 1984. And this clearly shows that at that time, 1984, 30 years ago, if you had a significant malalignment with the knees at that time, you would have an accelerated failure rate. And so if you think this was being published in 1984, and this is a 10-year follow-up paper, then the knees that David Llewellyn was studying were put in 1974. Okay, so with that concern about alignment. And look, he's calling valgus and varus not plus or minus 3, it's actually greater than 5 degrees in this paper. So just remember, that's a lot of malalignment. And the factors we've got to bear in mind, because Arun's presentation was wonderfully historical, like old, okay? So when you've got to think about what was going on in the olden times, okay, the design of the implant, the accuracy of our instruments, the fact that we were using very poor polyethylene, and we didn't really understand the knee kinematics. I mean, it's a shame, really. Arun is so young-looking. He's got all his hair. Why would it be that he would go back hundreds of years? And hundreds of years ago, of course, William Shakespeare was putting in flat-on-flat designs with very poor polyethylene. That led us to have edge loading. And, of course, with poor polyethylene, the polyethylene failed fairly precipitately. And so you can see there was a real reason why people were concerned about alignment in the olden days. Okay? And now we have, notice how my voice is much lighter now because it's much more exciting and sexy. We've got a new understanding that axial alignment isn't everything. The knee makes a series of complex three-dimensional movements, and we understand now the importance of rotation and gap balance. So it's not all about one parameter of axial alignment. Now, here are some of the studies we've done in Southampton. One of these videos is from Doug Dennis, but you can see that now we know the in vivo kinematics. The in vivo kinematics are from Doug Dennis, and then the modeling is from Southampton. And you can see why we're concerned. This knee was actually in 0 degrees of mechanical alignment. It was perfectly aligned on a plain X-ray. But functionally, because the intraoperative alignment of the prosthetic is not good, you can see how it edge loads, and you can see what effect that has on the polyethylene with the overloading of the polyethylene as it goes to single condylar wear. So you can see that wear now. So this knee was perfectly aligned, 0 degrees, but functionally is edge loading and is wearing out. So it's not mechanically perfect. And the result is that although it's well aligned on an X-ray and scores a 0, it's unstable in function and you get catastrophic polyethylene wear. And so last week, I asked all my theatre team to take their trousers off. Honestly, that's a normal request for me, actually. And you can see in my 3 registrars, we have different alignments. Actually, that's me in the middle, because you'll understand that actually I'm physically perfect. But you can see my valgus assistant on one side and my varus assistant on the other. Thank you very much. Just in case you didn't recognize me, okay, without my clothes on. That's valgus and that's varus. So only in me would Arun's knee replacement work. My other 2 colleagues would be disappointed. They would form the 10 or 20% of people who don't really like their total knee. Because they don't really feel normal when we put them back to 0. And that's where we get a 10, 20, sometimes 30% dissatisfaction with the function of knees, because this is all about function. And of course, now it's becoming appropriate now. So Aruna mentioned about the Ranawat Award. Well, here's my Ranawat Award paper to try and beat your Ranawat Award paper, looking at Johan Bellemann's work, where we can clearly see that none of us is 0 degrees. We're actually a little bit varus, and we vary with how varus we are. So it's certainly not 0 degrees. So we're putting them back to something they never were in the first place. And even though Arun was showing some papers showing increased failures for tibial malalignment, a lot of that tibial malalignment was quite severe, up to 6 to 8 degrees, and it was in old knees. And so if we look at a more modern paper, bringing Arun up to date from the olden times, this paper published 7 years ago from the Mayo shows that there really isn't a difference up to about 3 degrees of varus in survivorship. Now, beyond that, I think Arun may have a point, but up to about 3 degrees, what is reasonable is 3 degrees, and you don't see an accelerated failure rate. And so here's to make the point again from studies in Southampton, that at 0 degrees in a tibia vera, which is about what you are operating on here in this subcontinent, or in this continent, you are operating on a lot of people with tibia vera. If you put them at 0 degrees, the way they walk means that they will have, even at 0 degrees in a perfect knee, they will have liftoff and they will have edge loading, okay? Whereas if you put them in 3 degrees of varus, because that balances out the ligament forces in the cycle of how they walk, they will not lift off, and they will have much more physiological polyethylene loading. So you can see, although on an X-ray, this would be perfect at 0 degrees, functionally it's not. This would be less than perfect if you wanted 0 degrees, but functionally it's much better, and we can show that. And there's independent work showing that if you have a constitutional alignment in total knee, you get a better natural feeling because you have less soft tissue concerns, because there's more physiological stress in the ligaments. And therefore, here's a paper saying that you get better functional results, again from Johan Bellemann's, looking at knees with better KSS scores and better WOMAT scores when you go up to about 3 degrees of varus. So there's not a paucity of evidence, if you like. It's actually out there if you want to look for it. Now, what I'm talking about is a little bit of constitutional alignment here, and I'll talk about kinematic alignment in a minute. It's where the knee wants to be, where the ligaments and tendons are oriented along an axis they want to be, and the proprioceptive and neuromuscular pattern are not disturbed. So they don't feel right when they wake up with a knee at 0 degrees. And if the knee passively corrects, that determines my surgical approach to leave it in its natural alignment. So I've moved away from doing the femur first measure resection, if you like, and looking for predetermined angles and fixed angles for the femoral and tibial cut. I think if we use navigation, if we use a ligament gap balance technique, we end up with a constitutional alignment, a little different from the kinematic alignment, a constitutional alignment. And so I think that will give us better ligament tension, a more normal feeling in the knee, and better rehab with a more natural gait. What we're looking for here is not survivorship. We will take that as a given. What we're looking for here is function, which is what our patients are asking for us. They want better function in their knees. And so there's no doubt that mechanical alignment is historically derived, it's very safe, it's suitable for very demanding cases. Arun is absolutely right about that. When you've got those cases that he sees, mechanical alignment is the best way to go. But it isn't developed for the function of the knee. And now we have a new understanding of kinematics with new designs and reliable instrumentation. These new ideas on alignment will naturally follow. So it's about development. And there may be places for both approaches. And I've just talked about constitutional, and now Arun mentioned kinematic, and this is what we're up against. And you can see this is a typical case. There's no real point doing a kinematic alignment on this. It's wildly out of place, and actually 0 degrees is probably where you want to go, because this lady could probably hardly walk. But what I'm thinking about is, why don't we just change things a little bit and follow the epiphyseal line, which means you get an 87-degree cut on the tibia rather than 90 degrees. And you can see we do that all the time when we do a uni. So in that constitutional alignment I'm talking about, I'm not talking about the wild cuts that Arun had just mentioned. He just showed a case with a 14-degree tibial angle cut. I'm talking about an 87-degree cut within 3 degrees, But we ignore the anatomical landmarks. We ignore all those landmarks we've grown up with, and it's the strength and tension in the collateral ligaments that are the key. Now, if we go right onto kinematic alignment, it's been around for a while because Jim Rand used to do it. And as Arun was saying, the femur is oriented on the transverse axis, and the tibia is cut to match the femoral orientation. And the idea is, of course, that the collateral ligaments are balanced, and when they're balanced, the patella tracking works. The tibial cut is based off the lateral axis of the knee. And so this is the way he sets it up, with the tibial rotation being in green, and they construct that sphere, as you can see. And the purple line is the flexion of the patella axis. And so you take a symmetrical femoral implant and replace that sphere, which leads you to have a measured resection of the femur. So this is a little different to what I was talking about in terms of constitutional alignment. This is kinematic alignment. So what they don't want you to do is all the things that you have done with mechanical axis. They don't want you to cut the femur perpendicular. They don't want you to externally rotate the femur, and they don't want you to follow the epicondylar line. So it is really different. And it will end up with a different cut. And this is what Steve Howe points out, that actually if you compare the two, they're very different, and then you will alter your tibial cut to match that femoral cut. So that gives you a very different axis on the epicondylar axis and the transverse axis compared to the cases that we would do with mechanical alignment. So having made that slightly different cut on the femur, they then go to the tibia, and you match that femoral orientation. And that means that sometimes you will be outside that magic 3-degree figure, which is where this technique has picked up a little bit of criticism. And so we can accept that if that leaves you outside that 3 degrees, you might be making a failure scenario. And Steve Howell counters that with this paper where he shows that his results in pink compared with Jim Howell's 10 years ago, Jim Rand's 10 years ago, shows that actually the majority of his cases are in pink, are actually within 1 to 3 degrees of varus. It's only the real outliers that are over 7 degrees of varus. Most of them are in place. So in summary then, I'm saying mechanical is absolutely Shakespearean. It's Shakespearean in knee surgery. It's Shakespeare. It's stuff for old guys. Why don't we rethink a little bit? Because we know that 20% of the people are not so happy with their knees. We've got better, more robust materials. We've got intelligent design. We understand better the kinematics and soft tissues. So let's change our operative approach. Let's focus on better outcomes and function. And whether that's constitutional or kinematic alignment, I don't mind, but maybe we should move away from what we've been doing for the last 30 or 40 years. Thank you.
Arun, rebuttal. We get 2 minutes. We've been very generous on our time.
Right. So, David, I haven't heard anything to dissuade me from doing what I'm doing. The only thing I agree with you is unicompartmentals, you can align them as you want. I agree with you on that because it's a completely different ballgame. You have intact cruciate ligaments, therefore the loading can be completely different from a total knee. In a total knee, if you leave them with too much of varus, you're going to have loosening of the tibial component. So we agree on that yes, on the uni front, you can keep them in a little bit of varus, constitutional alignment, whatever you call it. Now, the first 8.5 minutes of your 9 minutes were talking about something else, and the last half a minute you spoke about kinematic alignment. So we really haven't heard any evidence from you, David, in support of kinematic alignment. You said that yes, we don't understand a lot about the normal alignment of the knee. I agree with you entirely. There are factors other than alignment. There's soft tissue balance, the pelvic obliquity, your gait, flat foot, your adductor, your muscles around the knee. All of these are very important. It's not just alignment, and I agree with you. So yes, you in the first part of your talk, you mentioned all the factors we don't understand about. But you have not given me anything in support of kinematic alignment. in the way Stephen Howell has described it, it's extremely difficult to reproduce what he says. The technique, if you go, I've read each and every paper of his. I sat for 2 hours with Stephen Howell in Gothenburg. He showed me all his x-rays. I showed him a load of my x-rays. And he said, I don't think it's a good idea for your country. Because of the sort of cases that we see, it doesn't make sense. We don't know so much about the bone quality. In our patients, we have a lot of osteomalacia. Now you leave a tibia in 4 degrees of varus, okay, even if your femoral component is in 7 or 8 degrees of valgus, some of that loading, shear stress is on the tibia. I mean, you're a professor of mechanical engineering. Come on, David, you know that that tibia is going to loosen out. You know, it's not going to survive, especially the bone quality is bad.
You got over your 2 minutes. We'll have to
You
let,
can't
we'll have to let David come up.
the bone quality.
Get off. Go on, get off. Honestly, Jesus. Right. Okay. So, thank you for that 3-minute ramble, Arun. That was great. So, do you know, I think there's probably a small aspect of truth in what you say, perhaps. And I think that I am uncomfortable with, what I wanted to do when we were debating is actually suggest that mechanical alignment wasn't the only way. I actually don't think necessarily kinematic alignment as described by Steve Howell is the only way either, because what he describes is a particular method of trying to achieve a kinematic alignment. But if you look at some of the work of Johan Bellemans, although he calls it constitutional alignment, I think it's still the same mindset of trying to work out where we position this prosthetic inside the knee to make sure all the ligaments are working as well as possible. And I think Arun's right again about unis, because we have a full set of ligaments, we can afford to work with those ligaments. The knee is always going to be, the knee joint replacement is always going to be a prosthetic. And positioning that prosthetic within the ligament envelope so as many of those ligaments can be happy and as physiological stressed as possible shouldn't be beyond us. And so it's not that I'm saying that kinematic alignment, as described by Steve Howell, is the only way of doing it, but I do believe there has to be a better way of putting the knee implant within that soft tissue envelope to make it work better for the patient. So even though we have long survivorship, we have 20% of our patients who feel uncomfortable because their ligaments aren't working as the way they should. And just adjusting it, and I entirely agree, some of Steve Howell's tibias at 14 degrees are bound to fail. And so that's why he stopped doing it in the States. So I think that within that acceptability of mechanical alignment, 0 to 3 to 4 degrees of varus, we can actually adjust how the tibia works, and we can make it work better for the patients.
Final rebuttal, 1 minute.
We didn't hear anything new. 3 points. There are no reliable instruments to perform this. If you can only use computer navigation to get it accurately positioned. PSI doesn't work, and that's been shown in many studies. We aren't even sure about the implant design, whether the implants are designed to do this, to take the alignment, because you are changing the femoral component, the trochlear groove, and we don't know what effect it's going to have on the patellar tracking. I mean, you're the master of the patellofemoral joint. How can you allow the femur to be internally rotated, tilted in valgus? It's completely unnatural. And lastly, you talked about the soft tissues. Now, the way in which we do total knee replacement, even in severe deformity, we've written up in the Bone and Joint Journal that you can do a soft tissue, you can do a correction of even severe deformity without releasing the MCL. So therefore, you've not altered the soft tissues. Stephen Howell and the other kinematic guys, their main contention was, because you're doing this, you've got to do a lot of soft tissue release and you're changing the soft tissue envelope. But that's not the case. You can do correction of even big deformities without touching the soft tissues.
Okay. Final, David.
It is very complex. Okay, but what I'm saying is that we have a lot of extra information now that means that we shouldn't hang on to the axial alignment of 0 degrees as being the gold standard, rather like a drunk person hands onto a lamppost, okay? We've got to be open to thinking about different ways of putting down the implant. And I accept that some of Steve Howell's work is quite extreme, and it is not necessarily something that I would do myself. But frankly, I don't want to put every knee in at 0 degrees, as you saw from my slide. I think Arun is absolutely right. It has to be done with navigation, and that's what I would use. If I'm cutting the tibia at 87 degrees, I want to know that's 87 degrees, so you need to use a navigation system. It doesn't work for PSI. So I think I just want to have people aware that there's a different way of doing it. There are cases that you see in this country that are entirely unsuitable to it because you have to have a good mechanical axis in someone who's got a lot of deformity. But I think that we should go away from this evening into the bar, awake to the possibilities of putting the knee replacement in just slightly differently. Thank you.